So, before we dive into today's session on primary care and cardiovascular diseases, I actually wanted to start with a quick scientific experiment. No blood required, no stethoscopes. So I'm going to tell a joke, and based on whether you laugh, I'll be able to tell a few things about you. Now bear with me, I'm generalizing using the Gaussian principle here for all the epi people. I'd be able to tell your age, your gender, and your profession. So, are you ready? So you're looking at me and thinking, wait, who wore it better, Zendaya or Dr. Khan? Now, if you laughed, you probably know who Zendaya is, which means you're under 35 and dangerously up to date with your fashion sense and pop culture. If, however, you didn't laugh, you might be over 50, a male, and probably thinking whether Zendaya is the new statin as a cardiologist. Either way, you now have mild tachycardia, a touch of confusion, and just enough curiosity to get me through the hour. So you've heard about Dr. Khan, and no, I don't think this is the Met Gala. I actually do have some credibility, so let me take a moment to introduce myself. I'm currently Director of Research and Policy at WISH, part of the Qatar Foundation. But over the past decade, I've spent a good part of my career focused on hypertension at the global level, working to accelerate the response through stronger, smarter primary health care. And today's conversation is exactly about all that, which is why I'm here. So let's get started. So today, as we mark World Hypertension Day, we're reminded that some of the most powerful solutions in health are deceptively simple and more urgent than addressing hypertension. To do this well, we need two things: interventions everyone can use and data everyone can trust. And there's no one who understands this balance better than the next speaker. Dr. Tom Frieden, president of Resolve to Save Lives, is a trailblazer who transformed lessons from decades of tuberculosis control into a global blueprint for hypertension. He recognized early that defeating the silent epidemic doesn't require complexity. It demands simplicity, consistency, and the humility to let the data guide us. Under his leadership, we've seen that checking blood pressure cuffs, prescribing affordable medications, and tracking progress can reliably save millions of lives. For me, Dr. Frieden has been a guiding light, a leader who distills public health into its most actionable form. When he first championed this approach, it wasn't just his vision that convinced me, but his insistence that the best interventions are often the simplest, but only if paired with reliable data to guide the path. That principle became my compass, and since 2017, I've dedicated my work to advancing this cause, because it proves that equitable care isn't about grand gestures, but getting the basics right everywhere. At WISH in Qatar, we've embraced this philosophy, using interventions that are evidence-based and scalable. We're trying to shape policies that actually work. It's not glamorous, but it is revolutionary, proving that simplicity, scaled with precision, can bend the curve on cardiovascular diseases and global health. Today, we have the honor of hearing from the man who taught us that global health progress isn't about reinventing the wheel. It's about rolling it out reliably to everyone. Please join me in welcoming Dr. Frieden.
Taskeen, I don't know who that person is you were describing, but I'd love to meet him or her. And thank you, Taskeen, for excellent framing of the remarks and the challenges. I'm going to take us through just a few slides that outline the fact that hypertension control can't be done without good primary care and what it's going to take to get there. Next slide, please. Where am I doing these? So I'd like you to meet a man who I met just 2 months ago when I was in rural India. His name is Jagannath, and he came into a primary care center to get treatment for his high blood pressure. Okay. So he is 70 years old. He didn't know he had hypertension. And if the WHO hearts strategy had not been there, sorry, this is... So this is a good source. You push backwards to go forwards. Sometimes in life, it's not as intuitive as you would think. He didn't know he had high blood pressure, and if the World Health Organization hearts policy had not been in place, it would not have been measured. His blood pressure was over 190 when initially measured. 15 minutes, 30 minutes later, it was still over 180, over 90. He got started on treatment the same day, and he now has a dramatically lower risk of having a heart attack or a stroke or kidney failure, and his back pain got treated as well. We have to focus on simplicity, as Taskin Khan said. Simple numbers, the control rate. Globally, the best estimate is that there are about 1.3 billion people with blood pressure over 140. Now, we all know that that's actually way above the normal healthy level, but let's just take it at the 140 level. And currently, we're at 21% control. That means that more than 1 billion people are walking around every day with their blood pressure out of control. That means that every second of every day, their heart is pumping blood that hits, just think of it this way, hits like a battering ram on their brain, on their heart, on their kidneys, every single second of every single day, because they haven't had effective prevention through reduction in sodium and increased potassium. They haven't gotten the penny a day of medications that could have controlled their blood pressure and saved their life. Our focus has to be on the control rate. This is the essential measure of how effective a hypertension treatment program is. It's not complicated. The number of patients on treatment with their blood pressure controlled over the estimated people with hypertension. Now, for an easier way of doing it, you can say the portion that are on treatment at that center. But please don't say the portion who came back for treatment, because that's what's called cheating. My very first public health lesson was by Carol Stieblo, a brilliant, brilliant epidemiologist who created the DOT strategy for tuberculosis. And what he explained was that tuberculosis control, and I would say hypertension control as well, is really very simple. There's only one rule. You are responsible for every patient, no cheating. If you're only measuring blood pressure in the people who happen to come back, you're fooling yourself about how your program is doing. You have to look at least at all patients who you've started on treatment, and ideally at all patients in your catchment area. Now, we analyzed a few years ago, very straightforward. By far, the most effective way to save lives is through blood pressure control in clinical care. Statins, which have changed since this slide was created, are the second most effective way, but very effective. Now, countries have a choice. Either easy actions that make little or no difference, like mass measurement of hypertension or exhorting people to exercise more or eat healthier, or school-based or youth-focused programs, or calls to action, quite frankly, or resolutions, or committees, or work plans, or strategic plans. These are all actually evidence-based ways not to make progress, because we've been doing them for decades and we haven't made progress. If you look at the places where we've made progress in NCDs, it's with focused capital, not just financial capital, but political capital. Tobacco control, trans fat elimination, real progress, saving lives. Now, oops. The WHO Heart's approach really is key. There are just 5 components. We have 5 fingers, so it's really good when you have a 5-component program. The first is a standard protocol, really important. Turns out 3 drugs can control at least 80% of patients' blood pressure, and add metformin and atorvastatin, and you've got 5 drugs, each of which can cost about a penny a piece on average, a little more for atorvastatin and losartan, but $5 a year per patient. Regular supply of quality assured medicines and validated blood pressure monitors. Team-based care, so you get the nurses and the pharmacists and the outreach workers involved. Patient-centered services, including free medications for patients. Hypertension is the silent killer. The first symptom is often a heart attack or a stroke. All over the world, people have to choose between an asymptomatic condition, treatment of their high blood pressure, which will kill them, or treatment of a symptomatic condition, hunger. And if we continue to require that patients pay for their medications, we will continue to fail to provide effective treatment to the vast majority of patients. Just think about it. We don't ask patients to pay for their anti-tuberculosis treatment or their vaccinations, or we know those programs would fail. So if we're going to scale up an effective program, it has to be free to patients. And convenient. That means free is not just free, well, you can take a 3-hour drive and wait 4 hours in the health center. No, convenient means easy to get to, respectful treatment, 3-month or 6-month prescriptions for stable patients, and powerful information systems, just as Taskin Khan said, crucially important to empower healthcare workers to continuously improve the quality of the care they're providing. So the keys are to improve hypertension control, measure blood pressure in all patients, all adult patients at least over 30, attending healthcare facilities. This is sometimes called opportunistic screening. You know, opportunistic sounds like a bad thing. Let's rename it to universal measurement of blood pressure among patients attending health facilities. This is basic quality of care. It's malpractice not to do it. Now, it doesn't have to be done by the doctor or the nurse. A trained health worker with minimal education and supervision using a validated device will not only do as well as the doctor or nurse, they will do better because they will monitor the 7 things you need to monitor to measure blood pressure. They will do the same thing each day, and they'll be able to speak with the patient, quite frankly, often more effectively than the doctors can. Ensure immediate linkage to care and treatment. One of the many failed models in hypertension treatment was, oh, exercise more, eat better, and come back in 3 months. That's basically telling people to go away and die. Because people don't have the ability to do that overwhelmingly. Maybe 2% can do it. The behavior change we need is not the behavior of patients, it's the behavior of policymakers to make physical activity easier with walkable streets, with cyclable streets, to make food, healthy food, cheaper with strategic subsidies on vegetables and fruits, to make junk food, unhealthy food, more expensive with taxes on sugar-sweetened beverages, with front-of-pack warnings as done in Chile and Argentina and Mexico and Colombia and elsewhere in the world, with taxes on unhealthy foods as done in Colombia. These are the behavior changes that we need, the behavior of politicians, not the behavior of patients. Medications have to be free of cost to patients. We've just reviewed this a couple of months ago. It's really quite striking. Even in higher income countries, even very modest co-payments that are trivial compared to the income of the patients result in substantial reductions in treatment adherence. So medications have to be free, but that means you have to fund primary care, because if you just eliminate the medication fees, you may be eliminating the salaries or the consumable payments for the healthcare facilities. So it has to be a strategic approach. and track and improve the control rate. Remember, that one number to look at, not the number of people screened, not the number of dollars or whatever currency spent, the number of patients on treatment with their blood pressure at target, whatever the country defines that target to be. Now, what's at stake? 50 million lives are at stake. If we look at actual, we've gone from 6 or 7 million deaths a year to 11 million deaths a year. And if we continue business as usual, we will get to 14 or 15 million deaths per year by 2050. But just with treatment, not even prevention, just with treatment, analysis shows that we can drive that number back below 10 million, 9 million, 8 million, back down toward the 6 million level, despite the fact that our population is growing and aging. It's not enough to reduce the rate of deaths from cardiovascular disease. We have to outpace population growth and aging so we don't have a more dependent, less productive, less independent society. Now, why isn't this happening? It took me years to wake up to the fact that it's not just about technical issues. Yes, those 5 components of hearts are essential. It's not just about operational issues. Yes, we need good supply chain management. We need good information systems. We need good management. But ultimately, hypertension control doesn't happen because money talks. Because hypertension isn't controlled since it does not pay to control it in most systems. Now, I don't think there's a doctor in the world who intentionally left their patients' hypertension uncontrolled in order for them to have a heart attack or a stroke or kidney failure. However, there are very few healthcare systems anywhere in the world that aren't structured to make that outcome nearly inevitable. It takes a lot of work to change that structure, to change the incentives, to have the incentives favor not hospital and specialist care, but better health, to have the incentives focus on a broad-based system that will not be cumbersome. There have been many attempts to have indicators. You may have heard of Goodhart's law. When a measure becomes a target, it ceases to be a good measure. Very hard to measure things and avoid either falsification or that one thing gets better, but many other things get worse, so you haven't really helped as much. Now, I want to talk a bit about primary care financing, and warning here, good thing it's before lunch, because for me, when I hear those 3 words together, primary care financing, it's just like, it's better than Ambien. I mean, I'm asleep right away. But we have to pay attention because it's important. And the emerging consensus is that the approach that's needed here is what's sometimes called capitation plus plus. Capitation is empanelment. It means that we pay a healthcare team a certain amount per month, quarter, or year for the patients with capitation at the center. Not the only payment, but at the center. And that capitation ideally should be adjusted based on the characteristics of patients. There are many other things that are needed. You need to empanel. You may need some sort of a gatekeeping function so that there's an incentive for people to go to their primary care practitioner. You may need better payment systems. It's not common in low and middle income countries. It's not common anywhere. But it does carry a great deal of hope for getting more value out of the dollars we're spending on healthcare and the dollars we're spending on primary care. Now, I say capitation plus plus because there are at least 2 additional things to consider. One is basic payments. We know that capitation isn't going to cut it for marginalized communities, for rural communities. You need basic infrastructure funded, and governments generally try to do this in many low and middle income countries. And you also need some sort of incentives to incentivize healthy practices. But rather than look at incentives, an emerging model that has a lot of promise is what's called the total cost of care. This is potentially optimal. And the idea is that the total cost of care is what the primary care team is paid based on. And if they prevent hospitalizations, they will make more money. And if they don't prevent hospitalizations, they will be penalized and lose money. Now, primary care is underfunded, so you have to make sure they're adequately funded when you do this. But the basic idea is that this would then align the interests of patients who want to stay out of the hospital, they want to be healthy, of doctors who can't stand the amount of bureaucracy they have to fill out with paperwork in many systems, filling out papers instead of talking to patients, and of the payers who actually don't really want to be paying for expensive hospitalization and specialist care that's not needed or preventable. So this is a potential way forward, not easy, but I think if we keep on doing what we've always done, we will get the results we've always gotten. And we can go a long way with the technical and operational improvements. We can get costs of medications down. We can use better protocols and maybe fixed dose combinations. We can get the cost of care down below $5 per patient in every low and middle income country in the world. We can get standard treatment of diabetes and hypertension and increase the use of statins, which will have a really big positive impact. We can implement maybe good information systems if we keep them simple, and empower healthcare workers to improve the quality of care. We can eliminate drug stockouts by having very advanced but simple ways of projecting the needs and tracking them. But even if we do all that, we're not going to have sustained positive progress unless we address the kind of payment systems that are dictating that we have the results that we have now. This will require more money, but more money is within sight. 4 health taxes, tobacco, alcohol, sugary drinks, and junk food, can generate tens of billions of dollars of revenue, can dramatically increase funding available to provide free medications for patients, to hire community outreach workers, to fix supply chains and information systems. Health taxes provide 3 big wins. Revenue that governments can use for socially responsible purposes, healthier populations that are going to live longer. When it comes to NCDs, nothing beats health taxes for impact, nothing. And lower healthcare costs. Now, I invite you to join in this call to protect 1 billion hearts. It's a global call to action to control high blood pressure. If you look at the QR code, you can download it, sign it, and be part of a global movement before, during, and ahead of the UN high-level meeting. This is a call for committed, urgent, coordinated action by governments, funders, the private sector to improve global blood pressure control from the current rate of about 21% to at least 50% in the next 5 years. This needs to be codified in indicators from the high-level meeting. This would prevent at least 75 million deaths, 150 million heart attacks and strokes, and prevent millions of people from needing lifelong dialysis over the next 25 years. So we encourage you to join us. We're proud of the partnership we have with World Heart Federation, and we do have a side event Monday from 6 to 8 p.m. that will cover the very important issue of access to antihypertensive medications. Thank you very much. It's an honor to be with you.
Thank you, Tom. And that was the perfect segue for my first question for Professor Salomon. For those of you who don't know, Professor Salomon is the ADG at the WHO, so many acronyms, Assistant Director General for UHC, Communicable and Non-Communicable Diseases at the World Health Organization here in Geneva. And the question that we cooked up for you is one really related to the high-level meeting. And what opportunities do you see for cardiovascular diseases in particular to be prioritized within the UN high-level meeting? And knowing some of the challenges and the barriers, how do you think this can advance cardiovascular health?
Thank you. Good morning, good afternoon, everyone. Thank you very much, Taskin, for your question, and congratulations to Tom. Really a brilliant presentation. I think everything has already been said, so thank you. You know, we are all facing 4 critical challenges first. I think the first one, most important one, is insufficient health workforce capacity, particularly at the primary care level. WHO estimates a shortfall of 11 million health workers by 2030, mostly in resource-constrained settings. Many countries lack adequately trained health workers at the primary care level who can deliver effective CVD prevention, diagnosis, and long-term management, as Tom very well said. And task sharing and team-based care models remain underutilized, especially in rural and underserved areas. So we have WHO's HEARTS initiative. Tom explained it very well. And globally, the HEARTS is now being implemented in over 40 countries. So that's already very efficient. The second point is about financial barriers and poor integration of CVD services into PHC and within health benefit packages. High out-of-pocket costs and poor access to essential medicines and diagnostics limit care for CVD. Lack of universal health coverage limits equitable access to life-saving CVD services in many low-resource settings. So WHO is supporting countries to overcome financial and service integration barriers by providing technical assistance to incorporate hypertension and CVD services into national UHC benefit packages, supporting the inclusion of a WHO-recommended essential medicines and diagnostics in national lists, and promoting the use of the WHO HEARTS technical package to integrate CVD care into PHC, and assisting countries to scale affordable service delivery models to reduce out-of-pocket costs and improve equitable access to care. And I think benchmarking is crucial. So for example, I would like to say that Ethiopia is a good example of successfully integrating hypertension core medicines into its national essential health benefits package. Third point, and thanks to Tom, it was absolutely obvious, we still need data and health information systems, because we are very happy with some weak data, but we shouldn't be happy with that. So many countries now lack reliable data for surveillance, monitoring, and evaluation of interventions. So the absence of national targets and standardized quality indicators for hypertension and CVD control hinders progress and accountability. So WHO is doing this benchmark and scale up innovative tools. We have Ethiopia, we have Ghana, we have Uganda, where we successfully piloted the use of e-tracker, a smartphone-based digital tool that empowers health workers to collect real-time patient individual level data and track patient progress over time at primary care facilities. And fourth point, and I think it's the most important now, just a few months before the UN high-level meeting in New York on NCDs, there is still a weak political prioritization of cardiovascular disease and insufficient financing. It's under-prioritized in national health strategies, budgets, and health sector reforms, despite being the leading cause of deaths with its massive health and economic impact. NCDs often struggle for attention compared to acute and communicable disease threats. So WHO is driving political commitment, including through the Heads of State-led Global NCD Compact, launched in 2022 in Ghana. This annual platform mobilizes national leaders to accelerate action and also to allow, accountability, because we need accountability, aiming to save, what Tom said, 50 million lives by 2030. This has led to impressive results, and just to say that, for example, Ghana, with a very strong high-level political commitment, catalyzed a national NCD dialogue led to the establishment of a multi-sectoral coordination mechanism and launched a comprehensive NCD strategy with CVD as a priority. To end about the high-level meeting on NCDs in New York, just to say it will be a unique opportunity to reposition NCDs and particularly CVD at the center of the global health and development agenda. And this is not only rhetoric, it must be a global call to action. Thank you for this QR code. And this call should be concrete, measurable, and time-bound with strong commitments. So it has to be a very strong call to the leaders to commit, to engage, to accelerate, to invest, to align, and be held accountable for action. Thank you very much.
Thank you so much. And thank you for underscoring the fact that cardiovascular diseases still need prioritization, even at the political level, that it still needs funding. I think that's pretty important to remember. You also mentioned several projects in Africa, which brings me to my next speaker, Professor Amam. You are on the ground in sub-Saharan Africa and perhaps seeing some of the complications of what we're talking about. So I'd like to ask you some of your experiences around what sub-Saharan African health systems are experiencing between heart failure, hypertension, and infectious diseases. And I'll pass over to you.
Okay. Thank you for that question. So we know that hypertension is a burden for us, and then if we can control hypertension, we can control a lot of the other cardiovascular diseases. The prevalence in my country is about 38%, and out of that 38%, only 9% who are on treatment are controlled. So that gives you an idea of what is going on. So the strokes are happening, the hearts are failing, and the kidneys are also failing. And there are a lot of issues. My health system is out-of-pocket payment. And for the patients, when they prioritize on the needs, what to do, antihypertensives won't be priority because there is no incentive for me to take the medications. I'm talking about 5 years, 10 years from now, the complications that would happen. And they are not seeing those complications. I'm the one who knows that what would happen. So they would rather take care of the daily needs, the food, the children, and all that, and then whatever is left is spent on medication. And also access to care. If I have to travel very long distances, to access care. And then for sometimes they stop coming because you come every 6 months and I write the same medication. So why should I travel so many kilometers to get the same prescription? So like we heard in the morning, we need to overhaul the whole system. Not just the system, even the healthcare givers. Sometimes we don't communicate with the patients. We talk down at them. I tell them this is there, but I don't get their own perspective. And that's why they're not listening to us. And then if they don't listen to us and if they don't take the medications, then those complications will happen. And we know that for us, strokes any day in the ER, strokes are coming in, the heart failures are coming in, and the CKDs are coming, the kidney failures. And it's so expensive to give any patient renal replacement care in my country. So I think getting them on the antihypertensives, preventing these complications is the way to go. And whatever we need to do that, we have to, do that. And then looking at it holistically, sometimes, I tell my patients, I said, you need to be careful because my students come into the cardiology clinic and everybody that walks in must have coronary artery disease. So it doesn't matter whatever you have. They wear blindfolds and it's only your heart. But I'm saying the patient is a whole. A lot more things may be happening. The problems may be more than what, cardiovascular at the point I'm seeing them. So we need to, change the way we look at patients, the way we organize care, the way and then the policymakers. Thank you. I think I'll stop there.
Thank you very much. I think you highlight what many of us have seen on the ground for a long time. and also support the health system, reshaping. I think those are really important and interesting to hear. You have a 9% control rate. Not fantastic, right? To say the least. My next question is for you, Dr. Roni. And honestly, I feel quite protected among so many people who are primary care advocates as well, and that's why I think I can push you a little bit. One of the things is this issue of scope creep and the idea that cardiologists in many settings need to see patients for simple hypertension. There's this myth that if you have simple hypertension in a lot of countries, especially developing world, that you should go see the cardiologist. As a practicing cardiologist, what are your thoughts on building a team outside cardiologists to actually treat hypertension?
Well, thank you for this question. Even when you sit on a panel at any level, you end up learning from each panelist. So thank you very much. There is not one answer. I'll go a little bit more on a bird's eye view. It was a transformative lecture to listen to when Jagat Narula gave a lecture on can we eliminate cardiovascular disease in our lifetime. Up to that point, it haven't really solidified for me that as you go through the checkpoints of modifiable risk factors, 80% of cardiovascular disease can be eliminated if we get to target. There is the other 20%, which we can talk about CRISPR and other things down the road. But we're not at 80% death reduction. But we're at 50, 60% since the 50s, about 60% in the US. Of course, ethnic communities lag behind for all the reasons we're hearing. So it's very empowering for the primary care physicians to know that the things that you do will really matter. And you can be very empowered to get to target. Post-MI, the European Society of Cardiology published that out of 36,000 patients, only 12% were a target for LDL. We're not talking sub-Saharan Africa. So don't just give the pill. Give it, get to target. Treat the blood pressure, get to target. Otherwise, heart failure, left atrial strain, atrial fibrillation, all these consequences that we see. David Dodick, one of my colleagues, interviewed Eric Topol recently on his book. And he said, we used to think it's 80% your genes and 20% what you do. The reality, it's the other way around, because even in 80-year-olds, they've been unable to identify genes as to why they're 80. So we all have the same reasonably not so great genes, but somehow the environment has triggered it. And the lack of modifiable risk factors, including socialization and post-COVID issues that we've seen. So they're things that the internists are also battling that's not in their control, like all of us. Today, pollution really outpaces even hypertension in terms of chronic diseases. Water, food insecurities, wars. After COVID, we still have wars around this planet. It's inconceivable. So this is the environment the internists are working in. So if you give me one moment to just go over some of the modifiable, which you guys have heard endlessly. But hypertension has been spoken about quite a bit, so do get to target. But as much as we need help taking blood pressure in the office with a lot of folks being seen, I recommend to take it yourself. I'm talking to the internist. Take it sitting, take it standing. In the elderly especially, they're dehydrated, they've got Parkinson's, autonomic dysfunction. You're going to end up over-treating them. So hypertension control and management of drugs is an art form. You have to do it very frequently and know how to weave between all these drugs and how to titrate them. So it takes a lot of practice, and teach the younger physicians and healthcare workers how to go about it. The next offender is clearly lipids, LDL. If we just targeted those two, we would be well on our way. Yes, it's smoking. Yes, it's obesity. Yes, it's lack of exercise and positive caloric intake. But the current European Society of Cardiology speaks of LDL less than 55, American Heart Association of 70, and it's really because we can only get 1 out of 4 to less than 70, but 1 out of 10 to 55. But there is really no floor in the LDL. So strike early, strike strong, especially post-MI, post-CVA. So those are real targets, and not just systemic and healthcare issues. One thing about weight, I don't want to go through the rest of them. Yes, 40% of the adult population over 18 is whether overweight or obese. And Rick has mentioned that as one of the things that are very much at the forefront. But you can be skinny fat. You can be skinny and have a lot of visceral fat and liver fat. So there are now imaging modalities that allow us to see what is happening in the liver. How much visceral fat? Is this patient pre-diabetic? Do they start with insulin resistance, get to pre-diabetes, diabetes, these chronic metabolic illnesses leading to disease? So I believe that we can target. I'm encouraged that we're not all genetically programmed to have an MI, because a lot of it is in our hands. And yes, we need population health. We need community and all the help we can get, but it's doable at the internist primary care level.
Thank you so much. I think you highlighted several things: non-financial incentives, respect for primary care physicians, and accurate blood pressure measurement, which has also been something at the core of primary care management. So for the next speaker, Dr. Elysia, I'm actually so interested to hear from you, because we don't often prioritize human rights when we think of cardiovascular diseases. And yet for a long time I've been thinking that what is a more equitable example of delivering care than to 1.3 billion adults who are affected regardless of gender, race, etc. So can you tell us a little bit of how you see the intersection of human rights and cardiovascular health?
Absolutely. So I am Dr. Eliezer Lapots Abreu, but everybody calls me Ellie. I feel it's easier. So I have the particularity of being both a lawyer and a health specialist. So I am the living proof of navigating those two worlds. In my family, you either have to be a doctor or a lawyer. So I said, hell, I'm gonna be both. But I'm sitting here in this platform, not only talking from my specialty, but also carrying the voices of the people in my community. So I live in the Dominican Republic, and the Dominican Republic is a very complex country, because it's home of Dominicans, but also Haitians. And lately, if nobody have seen that in the news, there's a lot of process going around access to healthcare for undocumented individuals in my country. And a lot of policies have been lifted and created with the basis of discriminating undocumented individuals. The thing is, cardiovascular disease doesn't have a passport. And hearts and cardiovascular diseases and non-communicable illnesses don't know zip codes, they don't know nationality, they don't know gender. And I think when we go from there and we look into some of the struggles that people face in our communities, then you can see that those social determinants of health that apply to other countries, sometimes they're a little bit different for us. So for example, we serve a population that lacks access to health education, have inaccess to water and sanitation services. But then when you look deeper into the people that are undocumented in our communities, they face other challenges. First is unemployment, gender inequities in terms of women accessing basic health services or basic medication. And despite us having a public health system is not very public and it's not very accessible for a lot of people. So part of our organization, what we do is creating a model that not only responds to the necessities of Dominicans, but also address immigration as one of those social determinants of health. And what I mean by that is that this is not a health model that is trying to recycle what other people are doing in other developing countries, but creating a model that is Dominican and that responds to the needs of the people that are living in the Dominican Republic. I'm going to give you just one example. Last week, we were launching a community clinic. And I was kind of taken back by the lack of diversity of that community clinic. And then I asked people that we partner with in the Ministry of Public Health on this lack of diversity in the patients that we were seeing. And they forgot to print the educational materials and the promo in Creole. So basic mistakes like that can really push a lot of barriers and really raise a lot of concerns in terms of accessibility. In our country, despite a lot of efforts being made, for example, we are one of the countries that have the HEART strategy implemented in our country, so we have access to affordable and free of cost medication for hypertension. However, that is not promoted among the immigrant community. The other thing is that physicians now are asked to share information about undocumented patients that they see. So patients are afraid of going to providers. And before, we used to have a lot of fear and a lot of distrust around public health. And now this is something that has really increased. So one of the things that I've always recommended, and this is kind of like my 3 takeaways, first is investing in human bridges. And what I mean about human bridges is us, people. Community health workers, community leaders, faith-based organizations that have proven to be very influential in our community and have served as liaison and bridges to health services. The second thing is paying attention to firewall policies. In our country now, it's required for doctors and hospitals to share private information on undocumented individuals. And this is something that, of course, is a human right violation, but most importantly, it really takes away the whole purpose of primary health care to be accessible, community-led, and focus on integrity and protecting the dignity of individuals. And the third thing is having people like us being part of the conversation. I think my story, and I'm sitting here in this panel with these amazing individuals, my story wasn't born in a boardroom, it wasn't born in a lab. I was born into these communities. So I feel like people want to be attended by people that look like me. People want to hear what we have to say. And I feel like people like us have really, really a powerful voice when it comes to policy changing. So if we want our politics to be inclusive, then allow us to be also on that table. Thank you.
Thank you very much. Really, really fascinating and wonderful to hear from you. I think you're really spelling out equity, aren't you? Next up, Dr. Dana, the lady with the money. So Dana is from the European Investment Bank, and we'd like to hear a little bit more about how the bank really thinks about infrastructure related to cardiovascular disease.
Thank you very much for the invitation. I'm really honored to represent the bank here, and as a former medical doctor, I'm humbled towards scared by the level of expertise in the room, as you can probably understand. But I'll focus on the financial capital part, as mentioned by Dr. Frieden earlier. In this context, the European Investment Bank, it's the bank of the European Union, owned by the member states, and that's where most of the focus of our intervention is. But we're one of the biggest multilateral development banks, and we usually support projects in the range of more than 80 towards 90 billion a year. Out of these, more than 3 billion every year it's invested in life sciences and health projects. And that's where I'm coming from, because even though we're a AAA bank, we do have sector experts that are evaluating these projects that the bank is financing, but also feeding back into the project promoters or our policy partner and guidance, which is the European Commission. So while I'll speak about the bank and what the bank can do, I think this event and exchange is more timely, considering that the European Commission plans for the new period are considering to have cardiovascular diseases at the heart, similar with how they had the cancer strategy and mission and the cancer beating plan. So I think we're getting there from a policy angle, and then coming back to where I come from a financing angle. And as the European Investment Bank, the word investment says something, and this is the fact that we mostly support infrastructure projects as far as the health interventions are concerned, but also we work with the life sciences, where this financial capital is a bit of a patient capital that makes possible that the research is translated into new technologies and medicines. It's a very particular market, as you probably well aware, and we are the champions in Europe in terms of providing this type of capital. While we're not yet at the level of the United States, I think we've seen a lot of development, particularly in the area of cardiovascular disease. Coming back to our infrastructure projects, I think we're guided by the same principles that have been already mentioned, so I will not insist more, but integrated and patient-centered care, and that extends the primary health care reach, including in the area of cardiovascular diseases. We're also looking at digitalization and the use of artificial intelligence. And we have, for example, a very recent project, and you might think, how is this linked with the primary health care, cardiovascular disease, and potentially even hypertension? It's a company from Iceland that developed an application that is prescribed as treatment within the healthcare system, covered, reimbursed by the insurance, that is helping the patient to manage the disease, the treatment and the disease. And this is the type of innovation that we bring into the treatment and particularly the prevention area. And while inside the European Union, where most of our activity is focused, the infrastructure projects are, let's say, classical ones, moving towards new models, but still we have the university hospitals, we have the new technologies, and this is something that we constantly finance. When it goes to our interventions outside of the European Union, particularly low and middle income countries, that's when we partner, because we're mostly a AAA bank with a stellar team of experts, but still a bank. So that's where we partner with our colleagues from WHO, for example, and we created what it's called a Health Impact Investment Platform, that it's taking the angle on the primary health care, also the banking angle. So we want countries to develop their own investment plans for primary health care with different angles depending on the situation in the country. I think we all know this can be very different. And that's where multilateral development bank like the EIB, like the Islamic Development Bank, hopefully soon the African Development Bank, put the resources together to help the country build these investment plans focused on different type of interventions. So then the capital can come from us, but not only. But that can be the plan, the investment plan to aggregate everyone towards the common policy goals. I can probably talk a lot more about what we could do, but I think for the purpose of today, it's important to know that we're there and we're contributing. We're not the obvious partner or visible partner, but we're really proud to be part of the ecosystem and to support both in the infrastructure and the research area. Thank you.
Thank you very much, Dana. I think we all learned a lot about banking from there. And so you bring me to the last panelist who I hope will put all of this together, really, as a founder of an intersectoral organization on NCDs. It will be very interesting to hear your perspective, Dr. Mark, on civil society integration and how this can be useful in the example of cardiovascular diseases.
Thank you very much, and thanks for the invitation to be here with this wonderful panel. So to start, I'm gonna bring some context. So I'm from Brazil, and in Brazil, similarly to other countries, you have 75% of the deaths associated with NCDs, caused by NCDs, and 40% of them are premature deaths. So they're a challenge that we need to address. And I'm going to share also some other data, but one data that I would like to share because of the topic here is that recently in Brazil we saw the data of adolescents and young adults, so the increase of infarction by 180% in the last years, so which means that almost 3 times was increased the number of infarction in young people in Brazil. So a lot to be done for sure, but I'm gonna share some good data as well, some good results. So in Brazil, primary health care has demonstrated its powerful potential alleviating the burden of cardiovascular diseases, particularly among the most vulnerable population. As you may know, in Brazil we have universal health coverage. Covering 80% of the population, primary health care has significantly impacted public health over the last decades, evidenced by its success in areas like HIV prevention and care, reducing maternal mortality, and increasing immunization coverage. However, addressing NCDs through primary health care has faced obstacles, including limited integration with specialized care, a lack of essential diagnostics tools, and primary level, and insufficient training for healthcare professionals in screening, monitoring, and adjusting treatments. This often leads to a cycle of prescription renewals without optimal management. So it disappeared, but that's fine. So basically, what I want to bring for you is that different programs were implemented in Brazil, and what we learned was that to be successful, they needed to be implemented in partnerships with public, private, not-for-profit, and academic institutions. And those initiatives, one of them called Cardio, that you'll learn more about tomorrow, another Health Rise, another Charming, and another Hearts, brought to the country successful examples of how organizing primary health care through empowering the healthcare professionals and also equipping primary health care was important to change this scenario. And this led to important changes such as the reduction of 1% in HbA1c in one of the programs, the 3 to 6 times more people screened, and also 3 times more people in target, and a reduction in more than 10% of strokes associated with those changes. And what we learned from that was that, first of all, it's important to be the multi-sectoral, so the sectors need to work together. In addition, the communities need to participate in discussions, and people living with the condition, so people, in this case, people living with hypertension, with diabetes, need to be invited for the decision that will affect them, and that we need also to pay attention to this, the specific challenges in each of the regions. Although the programs, they may have some overarching goals and overarching practices, there are differences in each one of the regions which is important to pay attention and to address.
Thank you very much. Unfortunately, we are very past the time that we were allocated. I know all of you want to spend a lot more time. The panel was excellent. I don't have time to ask them for one more statement, but I think they were good enough. You know, I think each and every one of them said all that they needed to say, and I think the session was simply fantastic. I hope you feel the same, and now we hope you'll make a healthy choice and not contribute more to obesity statistics at lunch. Thank you very much.